Hello, hi, ALD Connect community. My name is Patricia Musolino for the new people in the room. As all of the speakers before, we really miss being in the room with all of you, and we really look forward to having that opportunity again very, very soon. So I'm going to be presenting some of the preliminary analysis of some of those markers that we've been working on trying to understand how gene correction by hematopoietic stem cell autologous transplant with LENTB is working. How do we get the effects that we're seeing in the patients? And I'm going to be presenting some of this preliminary analysis. Since there might be people in the room and I've been looking at the different talks that may not be so familiar with the imaging side of how the disease progresses, let me walk you through some of the previous studies that we've done and trying to understand the imaging part and how the blood-brain barrier and the microvascular function has been altered in ALD. So I'm gonna share my screen and I'll start. So this study, or the results that I'm going to be showing towards the midway in the presentation, are from the cohort of patients that were treated with the StairBeam Bluebird Bio sponsor gene therapy trial here at MGH in Boston. It does not include the entire cohort of the multi-center trial. And this is currently being reviewed as we speak for publication. So hopefully the whole data will be out more complete in a short term. These are my financial disclosures. I've been working in ALD for more than 10 years now. I'm a passionate advocate of all the work that you guys are doing, not only here in the US, but across the world. And I'm gonna do my best to continue supporting the Spanish-speaking, Italian-speaking part of the community as I come from Argentina. And these are my disclosures. I consult for several of the industry partners that you've been hearing. And also I've received incredible support from MGH, from the university, from foundations. And recently, and just to celebrate, I gotten an R01 from NIH to study what are the molecular aspects of the blood-brain barrier in ALD. And we will be working with iPS cells and trying to model this in the dish. So for those of you that have just started in the disease community, we all know this is a disease caused by the ABCD1 deficiency. It affects boys and girls by altering the very long-chain fatty acid metabolism, which are increased, and that's how we diagnose them. Usually most of the boys, and the disease that I'm going to concentrate is not the one that we think affects the women. They go over a presymptomatic phase during childhood. And this is the most common age of onset, not the only one. We know now that the cerebral disease can occur in adulthood and in younger and older patients, but this is the most common onset of cerebral disease. So that's why the kids are being scanned in MRIs, because these lesions that start in the back of the brain, which this white patch that you see over here, they usually take several months, if not more than a year, to provide symptoms that you can see in the kid. And that's why we do the screening with the MRIs every six months. When you see the contrast enhancement, this is the gadolinium that is injected in the vein of the boys. And if the gadolinium gains access into the brain and shows like this, and Troy Lunt and many other speakers were talking about the blood-brain barrier, is that thing that is disrupted, and that's why you see the leakage of this contrast into the brain parenchyma with this particular sequence called T1. And we know that if you get that level of inflammatory response in the brain, the disease tends to go in a rapid progression. And there is a window for treatment that we are able to understand thanks to the work in bone marrow transplantation. And now we are starting to understand with gene therapy. And that's what we're going to try to present today, of what we see in these markers after gene therapy. So hematopoietic stem cell correction, we know, can halt the disease. It doesn't happen immediately. We know it takes several months. Troy referred to this in his talk, when he said, I see a little bit of progression, but we see this in transplant. We see it in all the patients. It's not an immediate effect after the transplant and engraftment, but a delay 6 months to 1 year after that, we see that the lesions finally halt. So if you zoom into that white patch, the lesion in the brain, you can see that there is this blue cells, which are inflammatory cells, that are now gaining access into the brain. And we think that this is a vessel, and these are inflammatory cells that are traveling from inside the vessels towards the brain. And the hypothesis is that these cells are eating up the oligodendrocytes, which make the insulation, which is the white matter, the myelin of the white matter. And that causes the demyelination. We did some work, preliminary work, back in the day. I saw that Keith has used some of this work in trying to track the effects of vitamin D in cALD boys, or ALD boys. And what we found, interestingly enough, is in MRI, we have a perfusion sequence. So we can see how this contrast gets in and out of the brain. And we saw that the blood flow to the brain was decreased ahead of that inflammatory edge where all those cells are extravasating and eating up the myelin. And that this microvascular, because those are the vessels that cause the blood flow to change, abnormality predicts the lesion progression. So 12 months later, you can see how the lesion went into that. And we at that time had very little data about how transplant worked. And we have here 2 patients, and we saw that from that decreased perfusion, if you were getting transplant, you could start to normalize that microvascular function. So it was very suspicious that this was really relevant in the disease pathophysiology. So when we think about microvascular flow, and if you look at a small vessel in the brain that breaks into, sorry about the mouse not working with me. If you take a small vessel and you see how they flow into the brain, you see the red blood cells, there's oxygen being extracted, that's why they turn blue. And then there are also white blood cells. But if the flow, it becomes abnormal, and these white blood cells start interacting abnormally with this endothelium, which makes the layering of all these little vessels, you can start seeing the disruption of that barrier that is the blood-brain barrier, and transmigration or invasion, if you want, of white blood cells into the brain. So the question is, how do inflammatory cells get into the brain, and how is it ABCD1 working? So let's step back and think about this, and I know Troy already introduced the concept. Imagine that this is now one vessel that you just section, and you kind of looking inside the tube, and you can see the cells passing by. And you have the inflammatory cells and the endothelial cells, and you see all these little molecules that are called adhesion molecules and integrins that are producing the interaction, so these cells kind of slow down. And it's like the way I think about the endothelial function in the blood-brain barrier is like the customs guy. And I've said this in ALD Connect in other meetings. And if you're going from one country to another one by car, and you want to get to the other country, get into another country, you will have to interact with the customs guy. So that customs guy in the brain is the brain endothelium. And this person that is trying to get in, let's pretend is the leukocyte. And in normal conditions, some of them are allowed to get in, some are not allowed to get in. But when there is abnormal function of the customs, then you get abnormal influx of cells or not enough cells into the brain. So how does ABCD1 causes alterations in these cells, the customs guys, the endothelium? So we saw in the past that this is a control. Each of these white dots is an inflammatory cell interacting with the endothelium in the background. And you can see in normal conditions how this is going pretty mild and slow. And this is like looking inside the vessel the way we were looking in the initial schematic figure. This is ALD. This is what happens after the brain endothelium has lost the function of ABCD1. The interaction with these inflammatory cells is exaggerated. There is a lot of these adhesion molecules that are increasing, and there is a lot of permeability changes, the leakiness that Troy was referring to. So the question is, can we assess these changes in this microvascular function, in the blood-brain barrier function, in vivo, in the kids, in patients? And can we determine the difference between these stages, the stages before the inflammatory cells come into the brain? And we know that not for having the deficiency of the gene, you are known to have the disease, the cerebral inflammation. Not every boy will have the cerebral inflammation. We know there are other events that need to happen for that kind of balance to tilt towards inflammation. And we are trying to also understand those second events. But the question is, can we see these live? Can we see it in patients? And I told you that initially with those preliminary studies of perfusion imaging, this is in the MRI, we see how the contrast can come in and come out. And the brain has multiple mechanisms to increase the blood flow when it needs more because it's doing more metabolic activity. One of them is increasing the flow by increasing the cardiac output, the way the heart pumps. The other one is at that microvascular bed that I show you with the vessels flowing, and instead of having a vessel flowing fast and another one flowing slower, you can homogenize the flow. And that's what we call capillary heterogeneity. If it's high heterogeneity, you have suboptimal blood flow. If it's low heterogeneity, everything is homogeneous, you have a much better chance of extracting the maximum amount of oxygen from your vessels. And this equation is what allows us to see the results that I'm going to be showing you. We map first what areas of that brain white matter were more susceptible to the ALD lesions. And we know it's mostly in the back of the brain, in the corpus callosum. And we found initially that this probability of having the disease is correlated with this microvascular dysfunction, in this case, by looking at the capillary heterogeneity. We also saw in some cases that this microvascular dysfunction, the CTH, and the permeability of the blood-brain barrier measured by something called constant up, which is the permeability constant, precede the very early lesion by more than 6 months, and at times for more than a year. So we knew that these microvascular markers are much earlier biomarkers. And in short, we kind of proved that microvascular dysfunction by CTH in this case, and this is going to loop again, is basically much larger than the lesion that we see in the T2, in that white patch that I show you in the MRI. And then with treatment, with bone marrow transplantation, we saw that this microvascular dysfunction can be restored and the lesions halted. So we know, and this has been presented also during the industry panel, that bone marrow transplantation is the standard of care for boys with cerebral ALD, and we learned that it can really halt the disease and save the life of these patients. And now we have in this study the comparison between patients treated with the standard of care with those that were included in the first clinical trial, ALD 102 of Sterbeam, where there were boys that did not have a donor. The second trial allows you to make the decision, but for boys that did not have a good match donor, they were able to enroll in this trial. And what we did is take their cells, correct them, put the ABCD1 gene back in, and after chemotherapy, to make room in the bone, as you heard, we put them back into the children. The mechanism of how these stem cells that are corrected get into the brain is not completely understood, but it's speculated that is by these cells called monocytes that circulate in those vessels that I show you that can migrate into the brain. And we saw that the blood-brain barrier is kind of open, so it's a good opportunity to get more cells transported into the brain. So we measure, as you know, the severity of the disease in the scans by a Lowe's score. And this is just to show you a patient before treatment and a patient after 2 years of treatment with the LNTD. And this is the natural history. What means is what happens with that score if you're not treated. And that's what a score of 15 will look like. And we know that the patients that are most likely to benefit from transplantation and correction of hematopoietic stem cells are those that have Lowe's less than 9. And we saw in this LNTD gene therapy trial that these lesions stabilize in the Lowe's score. But you can also see that there is a little bit of change at the very beginning, right after transplant. And that's what we were saying. It's always seen, a little bit of progression. But Lowe's score is not great for capturing the change in very small early lesions. And here I have an example, 2 examples of patients with very teeny tiny lesions. This white spot is the first indication of the cerebral disease. And 9 months later, you can see how much it grew. It almost tripled the size. It's still tiny, but it has been growing. And Dr. Malek is trying to determine and depict this biology with much more granularity and detail so we can understand early lesion development. And you can see how a lesion in a different part of the white matter in the front, this is one in the back, here you have one in the front, it also has changed significantly. And in this one, you can see how the low score has not changed. In this one, it starts changing from 1 to 2. So some of them, when the size is much, much bigger, you can start seeing the lows changing. Because of that, and because newborn screening, as you heard, is becoming the standard of care, and it's allowing us to detect these boys before they get any lesions in the brain. We are interested in understanding not just only how the lesions respond to this low score, but really getting granular on how much the volume of the lesions changed. And that's the dose of that correction of the gene, how much gene expression you have in those cells, modify the response to the treatment, meaning, is it going to be faster? Is it going to be slower if I have more gene correction, more copies of the gene, more cells corrected? So we look exactly at that. We look at the volume of each of these lesions. And you can see here a patient pre-treatment in that classic T2 lesion, and then how this evolves 1 year after treatment and 2 years after treatment. And you can see the lesion has grown a little bit. That is what we expect. But after 2 years, it pretty much holds on the same Lowe's score. And when we look at the volumes of those lesions, the white matter volume by just counting every single dot that is white, we see a very robust effect of the treatment. And here we look at the speed of growth. So before treatment, these lesions, and this is the most important point, were going really fast. They were like almost doubling their size, even though they were tiny, doubling the size before treatment. And then after treatment, you can see how that speed of growth flattens very rapidly and stays flattened. And then we compare those kids to a standard of care. So patients that were transplanted, that were patients at MGH with conventional bone marrow transplantation. It's a little bit more heterogeneous cohort. Some lesions went a little bit bigger, a little bit smaller, but very comparable to the kids that were enrolled in the gene therapy trial. We see something similar. We don't have the same granularity to see the early changes, but overall in the first year of after treatment, we saw that deceleration. So what about the white matter integrity? What does it mean? We have a marker in MRI, which is called diffusion. There's gonna be a lot more coming out as research continues to evolve in this field. And this is a marker of if these white matter tracks are really interacting and working or not working. And what we are seeing in FA, this is the more raw data of this diffusion sequence, is that indeed, in fact, after bone marrow transplantation, we do see a normalization of that white matter integrity. And this is, again, something that happens very rapidly after gene therapy. We see a similar effect in those patients that have been treated with bone marrow transplant. So I told you that we were interested in knowing is, does the number of copies of your gene, of the number of cells that are corrected matters? And we saw a very interesting correlation between the copies of the ABCD1 gene in your corrected cells. In hematopoietic stem cells, these are the ones that you're gonna be getting, the drug product. And we also look at the monocytes, the ones that are circulating around even a year after treatment. And the first thing is to notice these are in green, those guys, the hematopoietic stem cells, the ones that were corrected, the gene product before treatment. And you can see that the number of copies of the gene could go from 0.5 all the way to 2.5. And we were interested to see over time in these cells in the blood, how did we perform? Like, were these copies still being there? And the answer is yes, and it's a median around 1.52 for all of them. But we were also more interested in, is there a critical number? And the answer is appears to be the case. So somewhere around 0.7 copy number, so which is not an exact number, but it's also is where we see this incredible correlation with the speed of growth. So if you have a higher number of copies of the gene in your cells, you are likely to arrest faster. And that's something that we are still intrigued in how is it working. And we will continue to work on the biomarkers of these patients when the entire trial finishes and all the patients are being analyzed. So remember that when this first cohort was published in the New England Journal of Medicine. There was this question about contrast enhancement. So this is back to that inflammatory blood-brain barrier disruption. And we saw that all of them start with that because we did not include anybody in the trial that did not have contrast enhancement. And rapidly, at 30 days, the majority of them will resolve that contrast, almost all of them at 6 months. But there was something interesting on some patients having what we were reporting as recurrence of contrast enhancement. And we did put here some of those patients where you see the contrast before treatment and that recurrence. And you can see it's not the same thing. So the question we were trying to answer is, we have a much more refined look at the blood-brain barrier permeability with perfusion imaging. And we were wondering, do we really have that dysfunction of the blood-brain barrier changing over time? And we look at patients that have more delayed response versus those that have more rapid response. And those that have rapid response very quickly, you can see here in black, the alteration of the blood-brain barrier by cAP corrected that alteration, while other patients that were slower in responding had still abnormal cAP. So this is pre-treatment here, post-treatment here in blue for gene therapy, in red for hematopoietic stem cell transplant, conventional allogenic. And these are hemizygote patients, so ALD boys that don't have the cerebral disease. You can see that gene therapy almost restores that blood-brain barrier permeability back to almost pre-disease levels in patients with the gene mutation. And interestingly enough, and I'm putting it here, patients that self-arrest, which are a very small percentage of the patients that can do it by themselves, tend to have much lower constants of permeability in the white matter, so blood-brain barrier disruption. So to the question of those patients that were recurrent in contrast, and this is the MGH cohort exposed here, the answer is that constant permeability that is much more sensitive in perfusion imaging doesn't seem to change after treatment. So it's steady and it's sustained. And you can see it in this graph over here, which you can see that constant permeability in the blood-brain barrier, how it nicely not only remains low, but it continues to improve all the way to the time that we have follow-up for this patient, which is more than 2 years. And the interesting thing is that this was an effect that we saw for gene therapy, and we also saw it for bone marrow transplantation. We went even further and we wonder if, is this effect that we are seeing in the constant permeability in the lesion, in the demyelinating lesion, an effect that is also happening to the white matter distal and farther away from the lesion, so the rest of the white matter in the brain? And the answer is yes. You see in red is the lesional constant permeability, and in blue you see the distal normal appearing white matter. So this effect of the gene correction is going beyond the lesion to the entire brain, and it lasts over time. And then we got really fancy about some markers that tell you microvascular integrity. So if that network of capillaries is flowing with the normal architecture, and we saw that that architecture not only is getting better, but is getting better all the way to the point that we could see these kids in their follow-up in this analysis continue to improve. And this is something that we did not see the patients with the hemizygote condition without a disease and without treatment doing. They're very flat in there's this thing called vortex area, which is microvascular architecture. And this is here you have the monocytes, so those cells more farther down in the blood circulating, and these are the cells that are the whole hematopoietic stem cells. And you can see how that, again, the number of those cells that are expressing the ALD protein remain somehow constant and likely providing the effect that we're seeing. So with that, I want to close and open up for questions. We have learned in the past that ABCY1 deficient alters the brain endothelial selectively and increases their permeability to inflammatory cells. We know that gene therapy rapidly halts white matter lesion growth by volumes now verified, and that gene therapy can restore the white matter integrity, that diffusion marker that I was showing you. We also learned that this improvement in the blood-brain barrier permeability is a better biomarker than T1 post-contrast. So this is gonna bring a lot of discussions on how are we gonna be following the effects of the treatments that we're doing in these kids? And do we have the best tool to determine how they're doing? And we saw that this response is long-term. We saw also that these effects of the gene correction of the hematopoietic cells is long-lasting, but also extends beyond the lesion of of the inflammatory lesion in the brain to the entire white matter over time. So we learned also by this preliminary analysis that the correction of those cells by the vector copy number, the number of copies of the gene, it matters, and it matters both in the drug product and over time, and it correlates with that speed of disease regression or halting of the disease. So the higher your copies, the more rapidly you will stop the lesion growth, and the more rapidly you start seeing the normalization of the structure of the white matter and of the microvascular function. So with that, I want to thank mostly everybody in the room, but Dr. Eichler, who has been the mentor and the director of the leukodystrophy clinic and the Cerebral trial. Bruce Rosen has been one of the mentors and director of the Martino Center, which all this imaging advanced analysis is happening. And Anne Lauer is the postdoc that has done all of this work at the granular level, and Yi, Sandra, and Matthias, and many more have been involved in the lab in understanding this microvascular dysfunction in ALD. So with that, I will take the questions. So let me see if I can go to the Q&A questions. So I have Alex Scarpelli. My understanding is gene therapy reintroduces via IV corrected ABCD1 gene back into the patient at 20-25% maximum. Stem cell via donor direct match sibling is 100%. Do we know the difference in gene therapy versus stem cell via the donor if 25 versus 100% matters? So a little bit of a correction to that concept. The 25% of cells corrected is close to what we get with bone marrow transplantation in some patients. In bone marrow transplantation, as what we know so far, is not all the cells that the kid is gonna have flowing in their blood are gonna be the donor ones, because there is always a residual amount of stem cells that are their own. And we also know from women that don't get the cerebral disease that 50% seems to be enough. And that's what a heterozygote has, around 40 to 50% expression of ABCD1 in blood cells. So it's not 25 versus 100, it probably is more like 30 to 45% of cells that are circulating corrected. I will also pass that question to Dr. Orbach and Dr. Land, who had a lot more experience also with transplant, and Dr. Duncan. But basically, I think I show you the comparison head to head. It doesn't seem that gene therapy is as efficient, maybe even a little bit faster, and I don't have the information to say that because we didn't look in the bone marrow transplant kits so early on after the transplant. We usually have MRIs much more acquired in different timings, and that's why we don't have that information. I see a question from Cheryl Riley, and she says, does this information on microvascular changes change how recently diagnosed both MRI are conducted? Do you think that this new information will replace low score for identifying treatment options for boys? So the perfusion imaging is something that we've been pushing to have it once there is a lesion. At least that's something that we want to enforce, and it has. To the question of, are we going to be using this? We are currently using it in the trials to try to understand how these markers, the perfusion and these more granular volume measurements, can be used to really track the disease as it appears, and when we are doing treatments, how we're going to change that biology. So the answer to both of them is yes. the changes in the MRI protocol are there and proposed and available, but it's also going to be more coming out as we get the results from the trials. And I'm sure that the understanding of the early lesion is going to change the ground of treatment, because we're going to have a very different understanding of how these lesions happen, which we do not have at this moment. Justin Cullen, we are originally told that gene therapy will halt the lesion progression, but will not reverse the damage. So studies now are showing that the gene therapy, in fact, will stop the lesion progression and also reverse the damage. It does not reverse the damage. What I show you is the lesion volume. The lesions always evolve first, so they grow after treatment, and then there is a little bit of shrinkage on the picture that we get. But if you think about it, a lot of that white patch is swelling from the inflammation that there is. So when we stop the swelling, it's not unexpected that this T2 signal becomes a little bit smaller. So it does not resolve the damage. We do not know yet if we have any remyelination, and that's why we're seeing these changes in the white matter. That's a little bit of a stretch. We hope that there is something of that happening, but we don't have clear evidence. And that's why it's important to treat the kids early before they lose function. And I don't know how much more time I have. I have a couple more questions. Should I continue?
I have about 5 more minutes.
Oh, perfect. So Debbie Nagler, is bone marrow transplant and gene therapy offered to adults? Bone marrow transplant, it is. Gene therapy, not yet. And we have 2 types of gene therapy development happening. I'm just showing the one with ex vivo cells that Bluebird Bio has been leading. And there is also gene therapy being developed to be injected directly into the patients, and that's Swan Bio. And there is gonna be more to come. But the gene therapy in vivo is gonna try to address the adrenoleukodystrophy, which is gonna happen to adults. And we do not know yet if this will change the fate of cerebral adrenoleukodystrophy, the inflammatory disease in those adults. Chris Saraj, what vitamins or supplements do the patients take to help with the white matter not progressing after the gene therapy of bone marrow transplantation? So I will pass that question to Dr. Eichler and everybody in the room, because this is very variable. In terms of recommendations, we always check for vitamin levels, and there is the regular vitamin replacement that needs to be there. We know that vitamin D is an anti-inflammatory. We'd like kids to have normal levels of vitamin D. Before transplant and in the preparation, many of these kids for transplant, not for gene therapy, are on N-acetylcysteine supplement. After transplant, most of these people do not continue that N-acetylcysteine or any anti-inflammatory treatment. And that's because first, we don't want to interfere with the process of the treatment and the effect of the treatment. And second, because it seems to not be adding benefit. And we don't have perfect studies in that, but what the treatment is doing already is pretty good. And we believe that that's what we understand. Aaron Gardner, will gene therapy be available for AMN men? Again, I think this I answer with the Swan Bio. I think the hope is yes. And then would it prevent cerebral disease? We don't know it, but the gene therapy in vivo is going to try to target the symptoms of AMN and the degeneration of the lung tracts. Eric Hiller, would it be possible to scan for low microvascular activity to predict development of future lesions? That's what we are doing. Every kid that gets a scan in multi-center places that are having the capability of doing the perfusion is what we are studying. And if these studies become true, that all the kids will show us these microvascular changes before they show the T2 lesion, then we will put this in the recommendation. But remember always that before we can do things as a standard of care, we need to understand them very well. Remember that a lot of this is putting gadolinium in kids, and as of now, we're trying to minimize that amount of gadolinium because we know they need it for their whole life, and gadolinium can be accumulated in the brain. We don't know what it does. It seems to be tolerated, and in ALD, we still favor getting this contrast when needed because we know the disease is so bad. But as research evolves, I think we'll be seeing changes in the recommendations of imaging if we really truly confirm that we can see the lesions ahead of the T2 lesion that I show you, the white patch. Susan Marks, given the age of these children, does neuroplasticity plays a part? Always. the recovery, the tolerance to the treatments, and the way a lot of these kids are compensating for what has already been lost in the lesion from the damage that we see. And we're trying to understand in much more detail with neuropsychological testing, with cortical visual processing studies. How is it that the lesion is altering the kids before symptoms are more obvious, like vision, audition, and walking, and ADHD symptoms appear? For now, we do know that the young kids tend to have more aggressive type of disease, and that's why we rush in treating a very young population, a kid, 3, 4, 5-year-old child. But we also know that any kid during their journey of development will have a lot of more possibilities for compensatory mechanisms if there was anything lost, and for recovery of function because they are able to remap some of these functions. And this, we know it a little bit better, not from any ALD, but we do it from stroke and the traumatic brain injury happening in kids. So from a different population of patients. And then I have another question. I think we're done.
The next session. Thank you so much.
Guys, remember to go back to the agenda to click to the next meeting, to the next session.